This was the 56 years old male patient who presented to the emergency department with the typical chest pain. On ECG, there was a ST elevation in the V1 to V4 with the RWMA in LAD territory in the echo. Then after all clearance, patient was taken for the angiogram. This is a ileocaudal view, and you can clearly see that there's a thrombotic occlusion in the osteoprox LAD and the mid LAD significant. Same finding you can appreciate here. There was almost 70 to 80% thrombotic occlusion in the osteoprox LAD, and there was a subtotal occlusion in the mid LAD. And this was the epicranial view. Same thing you can appreciate here. And this was the RCA. This was the right radial route for the angiogram with the Tiger catheter. RCA was normal, dominant. So after obtaining all clearances, the patient was taken for the angioplasty with the same route, right radial route. This was the BMW PTCA wire. The catheter was XB 3.5. I made the knuckle in the distal LAD. It was a very small LAD, the distally. And this was the 2.75 into 20 stent was deployed in the mid LAD at 12 atmospheric pressure. Nominal was 8. And this was the scene after the stent deployment in the mid LAD. Now we proceeded for the osteoprox LAD. This was the positioning of the stent. Is very difficult to put the osteoproximal stent in the LAD, that too in the thrombotic occlusion. So I kept 1 or 2 strut in the LM. That is, I wanted to do nail the ostium technique, and the stent was deployed at around 14 atmospheric pressure. This was 3 into 13 stent, 3.5 into 13 stent. So after stent, the NC was done, as it was the Ostial LAD, and you can see the perfect expansion of the stent. And this view also you could see the good expansion of the stent. So this was the almost primary angioplasty to this LAD. A patient presented within the 2 to 4 hours of a chest pain, and he had a continued chest pain. So this was the primary angioplasty to the LAD in this anterior wall ST elevation MI patient.